In progress. Okay. So I will present first. My topic is about thalassemia. Let me share screen. Okay, can you guys see my screen?
Yes.
Okay, thank you. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Ahmad Al-Badawi bin Mustafa Ramzuan with matric number 1912695. So I will present today about thalassemia. First, this is my table of content. I will start with introduction and lastly go through the management. Okay. So, first for introduction. So what is thalassemia? So thalassemia is a congenital disorder characterized by the deficient synthesis of one or more of the globin polypeptide chains that result in imbalance between number of alpha and beta globin chains. This that will cause infective erythropoiesis, hypochromic RBCs, macrocytosis, hemolysis, that will consequently lead to anemia. So in simple words, it is a congenital hemoglobin disorder which due to mutation in the alpha or beta globin chains that will result in alpha or beta thalassemia. So worldwide, thalassemia, or especially beta thalassemia, is occurs mostly in Mediterranean, African, or Southeast Asian population. So in Malaysia, as of 28 November 2018, about 8,681 patients with thalassemia is recorded, with Sabah population is the uh, most percentage, which is 22.7%, following by Selangor, which is 14.6%, and Kedah and Johor about 8%. But the occurrence in male and female is about the same, which male to female ratio is about 49.6 to 50.4 ratio. And the age group, majority of thalassemia patient occurs in patient in 5 to 25 years of age, which is has a percentage of 64.45%. And the largest number of patient at age 10 to 15 years of age, which has 17.46%. And it is decreased in older ages, such as in 25 to 30 years old. It only occurs about 9.89%, and the least one is occurred in 85 to 90 years of age, which has only 0.06%. As we can see, this is the graph, and the occurrence of thalassemia occurs most in the younger age of children. And for ethnicity, Malay is the most is the majority of the thalassemia patient, which has a 64 around 64%, and followed by Chinese. Okay. Next, I will go about pathophysiology. So thalassemia, as I said, caused by mutation in the DNA of cells that make hemoglobin, which is a substance in red blood cells that carries oxygen throughout the body. So the mutation pass from parents to children. That's why it's called congenital. So in thalassemia, the production of either alpha or beta chains are reduced. They will result in alpha thalassemia or beta thalassemia. So in alpha thalassemia, the severity depends on the number of gene mutation inherited from the parent. So the more mutated genes inherited, the more severe the thalassemia. However, in beta thalassemia, the severity depends on which part of the hemoglobin molecule is affected. So we look at alpha thalassemia first. So in alpha thalassemia, there are 4 genes that involved in making alpha hemoglobin chain. So when the patient will get each one of us will get 2 from each of the parent. So if the mutated gene in alpha thalassemia is deletion at chromosome 16. So if one inherit one mutated gene, they will have no signs of symptoms of thalassemia, but they are a carrier of the disease and can pass it on their children. If the patient has 2 mutated genes, so the thalassemia signs and symptoms will be mild, and this condition might be called alpha thalassemia trait or alpha thalassemia minor. If one inherited 3 mutated genes, the signs and symptoms will be moderate to severe. If inherited 4 mutated genes, occurrence is rare and usually will result in stillbirth. As I said, so this is example in the picture. So one father has 2 mutated gene, and one mother has the mother is 1 mutated gene. So they can have all the possibility of the children to have either a carrier, which is 1 mutated gene inherited or normal, 3 which is moderate to severe sign and symptom, okay, and thalassemia minor, which is 2 gene inherited. In beta thalassemia, there are only 2 genes involved in making the beta hemoglobin, and beta globin gene located on chromosome 11, and mutated gene is labeled as B plus and also B0. Okay, so if in the picture, okay, if one inherit only 1 mutated gene, either B plus is a reduced production while B0 is excess production. So if there is only 1 mutated gene, so the condition is called thalassemia minor or beta thalassemia minor. Okay, and if there is 2 mutated genes, either both 2 are reduced production or both 2 is both 2 reduced production is thalassemia intermedia. If both 2 is absent production, then it will call beta thalassemia major. So if in beta thalassemia major, so there is no beta globin chain produced. So there is a beta globin chain deficiency, which this will cause free alpha chains to accumulate within the red blood cells, and they will clump together and will cause hemolysis. Hemolysis. The hemolysis can occur either in the bone marrow or extravascular hemolysis, which can occur such as in spleen. So as there is hemolysis of the red blood cells, will increase the hemoglobin to spill out directly into the plasma, where heme is recycled into iron and also unconjugated bilirubin. So the excess unconjugated bilirubin will cause jaundice in excess iron deposit, will lead to the secondary hematochromatosis. So at the same time, as the RBC is hemolyzed, so the patient will become anemic. So which will lead to hypoxia, as there is less oxygen carried by the RBC. And consequence of hypoxia, it will cause extramedullary tissues such as liver and spleen to increase red blood cell production. So the thalassemia patient will have enlarged spleen and liver, and also there will other bones that has bone marrows can also be enlarged, such as usually skull and face bone. Okay, next I will go to the clinical manifestation. First, I will go through about presenting complaint or history that we can take from thalassemia patient. So usually, in general history, we can patient will have failure that is due to anemia. Second is jaundice due to increased RBC distraction or hypersplenism. Third is growth retardation and delayed puberty. Other than that, can concentrate, lethargy, leg cramp, fast heart rate, fast heartbeat, shortness of breath, dizzy, and headache. Then that in the past medical or surgical history, we can ask splenectomy as it can in thalassemia patient. Some will have splenectomy. Okay, and immunization is important to us in thalassemia patient, especially in patient that need chronic transfusion. So the patient needs to have hepatitis A and also hepatitis B immunization. That we can ask any allergy. And the fourth one is family history, which are very important because it is congenital, and we need to know the genetic status of their parent and also their siblings, which we need to know if their siblings are affected and on, and we need to know the severity and treatment. The first one is birth history. Is there any neonatal anemia or G6PD deficiency? Lastly is dietary intake. Is the patient has restricted diet, such as consume less iron, like consume less red meat. Next is clinical manifestation of physical findings or signs. So on general expansion, we can find brown skin color, short stature, thalassemia faces, such as frontal bossing, maxillary overgrowth, and myeloaminence. And we can also see pallor in the conjunctiva and also palmar crease, and jaundice in the sclera. In the abdomen, we can see if the patient already done splenectomy. The surgical scar, this picture is a laparoscopy surgical scar. If it is open splenectomy, the surgical scar is made incision. And if the patient doesn't have any surgery, um, we can detect hepatosplenomegaly in the thalassemia patient. Then as the patient is become anemic, and we need to know is the heart is affected or not. Okay. Next, I will go through the complications. Okay, first, iron overload. It can be due to long-term complications of chronic RBC transfusion. First, it can cause cardiac damage or cardiac involvement, which it can lead to cardiac failure or arrhythmias, which are common fatal complication in chronic transfusion patient. So this cardiac involvement, this complication can be avoided by adhere to chelation drug or therapy. And other than that, it can involve endocrine, which can cause hypogonadotropic hypogonadism, diabetes, or pituitary damage. So, hypogonadotropic hypogonadism is common in young age group that can lead to infertility. So there are other complications that caused by iron overload. So in this picture, next complication will be alloimmunization. So usually happen in the uh, in blood transfusion. Okay, so a patient is recommended to do extended RBC antigen or multiple alloantibodies so that blood can be transfused safely. Next complication is viral infection. Is usually blood-related pathogens such as HIV, Hep B, Hep C. So in order to avoid this, detailed questionnaire need to be asked. Okay. So next is hepatosplenomegaly, which is common because there is extramedullary hematopoiesis and also increased iron accumulation that can lead to liver cirrhosis. So for spleen enlargement, hypertrophic response related to the extravascular hemolysis. Next is growth retardation. So usually due to dysfunction of the growth hormone and insulin like growth factor 1 axis. Next is osteoporosis. So it can be either from marrow expansion or endocrine deficiency. Okay. Okay, so I will go through the investigations of thalassemia. So initial investigation is to be done is first complete blood count, which we expect to have a macrocytic hypochromic anemia or microcyclic MCV is less than 80 femtoliter, MCH less than 27 picogram, and high RBC kan then iron deficiency anemia patient. Second is hemolysis evaluation, and we need to do count test. Usually the result will be negative as it is non-immune mediated anemia, low heptoglobin, high LDH and high reticulocyte, hyperbilirubinemia, indirect. Next, iron study or ferritin study. So usually normal in thalassemia, but it can also increase in thalassemia major patient. So usually increase in other condition like sideroblastic anemia and iron overload. Third is a peripheral blasphemia. We expect to see anisopoikilocytosis, which means red blood cells and is different in size and shapes. Vary in size and shapes. Okay, increase in RDW, red cell distribution. And then that we can see target cells and teardrop cells. So for confirmatory investigation in thalassemia, first is we need to do HB electrophoresis. So in thalassemia patient, the HbF and HbA2 will be increased as there is this disruption in the production of HbA, which is the major types of hemoglobin, major types of red blood cell in adult. So HbA2 finding is important to distinguish between alpha and beta thalassemia. Second is high performance lipid chromatography. So we need to quantify HbA2 and HbF. HbA2 4 to 9% in severe or heterozygous beta thalassemia. HbA2 3.6 to 4.2% in mild cases. And the third one is DNA analysis, which we identify globin chain synthesis and structural analysis. And we use when unable to detect hemoglobinopathy from hematological tests. Okay. The next point is about differential diagnosis. Okay. So first one is sickle cell anemia. So it's a genetic defect causing sickle hemoglobin, like the picture. Usually due to permutation of beta globin that lead to glutamic acid to valine conversion. So how to differentiate? Sickle cell anemia is usually has MCV less than 80, but it can be normocytic. It can cause vaso-occlusion in peripheral, lead to pain. Then patient can also have acute chest syndrome, and the presence of sickle cell on peripheral blood smear. Second is iron deficiency anemia. Etiology is a loss of iron due to occult bleed. The bleed means a problem in dietary intake. So how to differentiate is usually also microcytic, but it has low serum iron, elevated transferrin, low transferrin saturation, and low ferritin. And we can check the occult blood. The third one is hemolytic anemia. So it is autoimmune toward RBC that can be inheritance or acquired cause. So inheritance such as RBC membrane defect or PV kinase defect. If acquired is drug induced, such as drug penicillin, ampicillin, and immune mediated is auto allo antibody. The fourth one is vitamin B12 or folate deficiency, which etiologies cause pernicious anemia, nutritional deficit, Crohn's disease at terminal ileum, which is the patient is unable to absorb B12. And how to differentiate is usually macrocytic for more than 100 femtoliter, low vitamin B12 or folate, and it is a megaloblastic anemia with hypersegmented neutrophils. Next, the last part is about management. So first, blood transfusion usually start after done blood investigation. So and then we need to do hemoglobin analysis, infection screening, and RBC phenotype before transfuse. So the target is pre-transfuse maintained at 9 to 10. Okay, as post-transfusion, we keep around 13.5 to 15.5. We need to keep the mean hemoglobin of the patient between 12 to 12.5. Usually done for weekly interval, but it can be 3 to 6, depend on the patient. Volume usually 15 to 20 mils per kilogram per RBC. The second we need to do is iron chelation therapy, is to prevent iron overload in transfusion dependent thalassemia. Okay, example is desferrexamine or desferral. The aim is to keep serum ferritin below 1,000 gram per liter. Second is defepron or feriprox. Oral iron chelator is alternative, okay, but it has complications such as GI problems, arthritis, or granulocytosis. And the third example is deferasirox, or we call FJ. Okay, so it has complications also such as rash and also GI problem. The third one is diet and supplement. So the patient need to have oral folate 1 milligram daily at minimum, vitamin C 3 milligram per kilogram for increased iron excretion. So the patient also need to avoid iron-rich diet such as red meats, nuts, and seafood. Or the patient need to drink tea to minimize iron absorption. The next management is bone marrow transplantation. So the patient need donor that is HLA compatible. So it's classification of patient into Pesaro risk group based on the presence of three risk factors. First is hepatomegaly more than 2 cm, iron chelation, and presence of liver fibrosis. Last is splenectomy. So we do it when there is hypersplenism, and RBC more than 1.5 time or 200, more than 200 or 220 to 200 to 220 mils per kilo per year in the age of more than 5 years old. And splenectomy need penicillin prophylaxis, need pneumococcal and HB vaccination 4 to 6 weeks prior to surgery. I think that is all from me. Is there any question or comment from Dr. Shahid?
Okay, any questions from you guys? It's quite comprehensive now. Did you guys get to meet any thalassemia patients in clinic? Ada?
Daycare.
Daycare lah. Ada yang ada hepatosplenomegaly semua tu ada jumpa lah.
Ada, pernah jumpa.
Ada. Okay. Any question? Kalau tak ada, we proceed to the next topic lah.
Doctor, I have one question. During my clerking, most patients says that they have usually have prolonged fever during childhood, and then they were diagnosed with thalassemia. May I know the reason why they have prolonged and of fever during childhood?
Actually, maybe just something incidental lah. Usually, you won't be checking FBC for no reason kan. So macam sometimes it's just coincidental lah. Masa kecil-kecil ada demam and then check FBC, just noted ada anemia lah. So it's not a usual presentation of a thalassemia lah. It's just something coincidental saja.
Right, thank you, Doctor.
Assalamualaikum warahmatullahi wabarakatuh. Assalamualaikum warahmatullahi wabarakatuh. My name is Irina binti Romzi, which is metric number 1919092. So I will be presenting on the topic of the immune thrombocytopenia, also known as the acronym of the I. Okay, so this is the flow of my presentation. Firstly, I will introduce to you what is the ICT, and in my introduction, I will briefly explain the definition and also the epidemiology and the classifications of the ICT, and then we will look into the pathophysiology of the ICT and the clinical presentation, and then the differential diagnosis, investigation and management of the ICT, and lastly, we look at the sample for the ICT. So, what is ITP? ITP previously known as the immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura. But nowadays we call it the immune thrombocytopenia because not all the cases of the ITP present with the purpura. Hence, we change the name to the immune thrombocytopenia. And ITP is one of the commonest causes for the thrombocytopenia in the children. And ITP will present after 1 to 4 weeks post-viral infection or recent vaccination. And ITP itself is a diagnosis of execution. So it's very important to take a full history so that we can exclude the other diagnosis so that we can say that the person has the ITP. Okay, so for the definitions of the ITP, so we will go word by word firstly, and then I will define the ITP. So ITP, the immune. So when we talk about immune, it means that our own body will produce the antibodies against our own cells. So in the ITP, our own bodies will produce the antibodies against our own platelets. So it's called the autoantibodies. And then the thrombocytopenia. So the thrombo is thrombocyte, which means platelet, and penia means that the count of the platelet is low. So thrombocytopenia means that there is the low platelet count. So the immune thrombocytopenia is actually the autoimmune disorder that's characterized by the autoantibody-mediated immunologic destruction of the normal platelets that mainly occurring in the skin and in response of an unknown stimulus. That's why previously it's also known as idiopathic thrombocytopenia purpura because the stimulus is unknown. And in children, the ITP usually acute. So what means by acute childhood ITP? It is a benign self-limiting disorder. So why is benign? Because it's not life-threatening. And self-limiting disorder means that it can resolve spontaneously with or without the treatment within 6 months. And it will present with the isolated thrombocytopenia with the count of the platelet is less than 1,000 times 10 to the power of 9 per liter and in absence of the underlying causes. So in the acute childhood ITP, it can progress, it can have the recurrence, which is around 5% of the patient's acute ITP. And also the acute ITP can progress to the chronic or persistent ITP, which is around 10%. Okay, the next one is the epidemiology of the ITP in the children. So the prevalence of the ITP in the children is around 4 to 5 in 100,000 children. And for the age, the peak age for the diagnosis of ITP is around 2 to 4 years. And for the gender, the ITP equally affects both girls and also boys. Okay, the next one is the classifications of the ITP. So ITP can be classified into two generally, which is the acute and also the chronic. So firstly, the difference between acute and chronic is duration. So for the acute, the duration for acute ITP is around 1 to 2 weeks, but for the chronic, it's around more than 6 months of duration. And for the acute ITP, it's more common in the children, meanwhile for the chronic, it's more in adults or teenagers. And the gender for acute, it affects both sexes equally, and for chronic, it affects more in the women. And the onset for the acute ITP is rapid because it's acute, and for the chronic one, it's insidious. And acute usually has the history of the recent viral infection or recent vaccination. And for chronic, usually it has the associated with other diseases such as there's autoimmune disorder like SLE, malignancy like CLL, and non-Hodgkin lymphoma, infections such as HIV or Epstein-Barr virus and Zika. And for acute, it has a good prognosis where it can resolve itself in 90% of the cases. Only 10% of the cases can become chronic. Meanwhile, for the chronic ITP, it can persist for more than 6 months. Okay, this is another classification from the six protocol. So this is from the International Working Group proposal on the classifications of immune thrombocytopenic purpura. So these classifications of ITP is based on the phases of the disease. So there's 4 phases for the ITP. Firstly, we have newly diagnosed ITP, which is within 3 months from the diagnosis, and then we have the persistent ITP. So this persistent ITP is between 3 to 12 months from the diagnosis. And we have the chronic ITP, which lasts for more than 12 months. And we have the severe ITP. So the severe ITP is actually when there's the presence of the bleeding symptoms, and then we need to do the treatment, or there's new bleeding that require the additional therapeutic intervention or a different platelet enhancing agent, or we need to increase the dose. Okay, next we will go to the pathophysiology of the ITP. So as I told you earlier that the ITP is the autoimmune disorder. So it means that our own antibody, our own body will produce the autoantibodies. So the autoantibodies are IgG. So this IgG will be attack the platelet membrane antigen. So the platelet membrane antigen is called the glycoprotein. It's called the GP2B3A complex. So this IgG will bind to the glycoprotein GP2B3A complex. So after the binding, so it will cause the antibody coated platelet to be recognized by the antigen presenting cell, which is the clinic macrophage. So this will cause this platelet to be ingested and to be destroyed. So it will result in the reduce of the platelet count, and to compensate the reduce in platelet count, so the bone marrow will try to produce the platelet by increase the production of megakaryocyte, which is the platelet precursor. Okay, the next one is the clinical presentation. So clinical presentation for the ITP. So see that it is the ITP itself for the children is on the onset is acute. So and the presentation is usually abruptly, and it must have the history of preceding viral infection in the past 1 to 4 weeks. And usually for the presentation for ITP is due to the bleeding. But the bleeding is not the deep organ bleeding, but just cutaneous bleeding. So we have the a few spectrum of the bleeding severity. The first one we have cutaneous bleed. So this cutaneous bleed such as the petechiae, purpura, and ecchymosis. So the difference between these three is actually is in the diameter. So for the petechiae, the diameter is less than 2 millimeters. For purpura, it's between 2 to 10 millimeters, and ecchymosis is more than 10 millimeters. And then all of these cutaneous bleed is in colored red or purple. And then we also have mucosal bleed. So for this mucosal bleed, it can cause the gum bleeding, or it can cause the epistasis. So epistasis is the nose bleed, or it can cause the gross hematuria, or in the girls who already achieved the menarche, so it can cause menorrhagia. And the last one, which is the life-threatening bleed, so it can cause the intracranial hemorrhage. So this is the immediate medical intervention. And if we do the physical examination in the patient with ITP, there's no hepatosplenomegaly, and there's no lymphadenopathy. So if there is splenomegaly, so we can exclude the diagnosis of ITP. Okay, so this is the image for the presentations of the ITP. So we have the petechiae, which is less than 2 millimeters, purpura, which is between 2 to 10 millimeter, and we have the ecchymosis, which is more than 10 millimeter. So this is also the trend. This is the ecchymosis, and this is the petechisis. We have the gum bleeding, we have the epistasis, and we have the hypertension in the CT scan that shows the intracranial hemorrhage. Okay, so this is just the pathogenesis and the clinical findings. So the blue one is actually the physio of the ITP. So the result for the ITP is called the reduce in the platelet in the bloodstream. So when there's the reduce of the platelet in the bloodstream, so the platelet is insufficient to cause the clot. So it causes the patients to have easy bleeding. So it can cause the bleed under the skin. So it can lead to red or purple discolorations of the various parameters, such as the decay, purpura, and ecchymosis. And it can cause the mucosal bleeding too. And rarely it can cause the serious bleed, which is the intracranial bleed. And also in the reduced number of the platelets, so it can cause the reduced lifespan of the platelet in the bloodstream. So bone marrow try to compensate by increase the platelet production. So we can find there is increase or normal megakaryocyte in the bone marrow biopsy, and also we can find increase of the immunocyte platelet from the bone marrow. So when we do the peripheral blood flow, we can see there's the large platelet. Okay, so the next one is the differential diagnosis or ITP. So the platelet, so the differential diagnosis can be due to the first one, platelet count reduced, which is the thrombocytopenia, or maybe the platelet count is normal, but there's neither causes that can cause the platelet the differential diagnosis. So the first one we have for the platelet count reduced, it can be due to the increased platelet distraction or consumption, or it can be due to the impaired platelet production. For the platelet count normal, it can be due to the platelet dysfunction or can be due to the vascular disorder. So the example of the diagnosis for the increased platelet distraction, such as the SLE, the other immune neonatal thrombocytopenia. So this is for the immune. For the non-immune, it can be due to the hemolytic uremic syndrome. So this hemolytic uremic syndrome is due to the bacteria, which is the Schiedam toxic and enterohemorrhagic E. coli, and then the thrombocytopenia purpura, the disseminated intravascular coagulation, or can be due to the congenital heart disease, can be due to the cancer, which is the giant hemangiomas, or due to the hyperthyroidism. And it can also be due to the impair of the platelet production, can be in congenital. So congenital usually due to the mutation, like in cytonic anemia, or whispered Edridge syndrome with presentations of edema usually, and we have the Bernard Solier syndrome. And we also have the acquired, like aplastic anemia, the bone marrow infiltration, for example, like leukemia, and drug-induced thrombocytopenia, such as the drug that can induce the thrombocytopenia is the heparin. And then for if the platelet count is normal, so we can think about the platelet dysfunction. So in congenital, which is that very rare, but it can cause the plasma thrombocytopenia. So tenia is mean that reduced in power. So thrombocytopenia is mean that the platelet is reduced in power, so it causes the platelet dysfunction. And we have the Hermann-Stein blood symptoms type 2. And for acquired, we have the uremia, and we have the cardiopulmonary bypass. So for the vascular disorder, congenital, again, it's rare disorder like Ehlers-Danlos, Marfan syndrome, hereditary hemorrhagic telangiectasia, which means that the dilatation of the small artery, and we also have acquired like meningococcal or other severe infection, and we have the vasculitis like Henus colon purpura or SLE. And the last one we have the scurvy, which is the deficiency in vitamin. Okay, so as I told you in earlier, that ITP is a diagnosis of exclusion. So in order to make a diagnosis for patient to say that he or she has ITP, so we need to take the history, and then we need to do the physical examination. So we need to exclude the other causes of the thrombocytopenia, like the stigmata of Mendelian disease or congenital thrombocytopenia. And then we need to do the investigation such as the full blood count. So in the full blood count, we can see there's the isolated thrombocytopenia. And when we do the examination of the peripheral blood smear, So we need to exclude if there is any abnormal cells. Okay. So in history, so what can we get from the history is that the patient previously well, and then it has the acute onset of bleeding, such as the epistaxis, the gum bleeding, or the blood in the urine or in the stool, and unusual heavy menstrual flow. But all of this onset of the bleeding is unexplained and it's prolonged. So we can think of the IPC, and then the patient also has the history of the fever, 1 to 4 weeks post viral infection or the recent vaccination, and then there's no other symptoms such as weight loss. So exclude the other causes of the acute leukemia, and then the history of the exposure to the thrombocytopenia inducing drug. So we need to have drug history, we need to have the transfusion history too, and lastly we need to have the family history of the bleeding disorders. Okay. So for the physical examination, we can check if the patients have the mucocutaneous bleeding, such as the petechiae, purpura, and ecchymosis, and there's no lymphadenopathy, and there's no hepatosplenomegaly. Okay. For the investigation, so the investigation that we can do is first, we can do the full blood count. So what our expected finding is that there is the isolated thrombocytopenia, which the count is less than 1,100 times 10 to the power of 9 per liter. And then other than thrombocytopenia, other parameters are normal, such as hemoglobin and also the white cell count. And for the peripheral blood count, we can see there's the reduced and large platelets, but apart of that, there's normal and there's no abnormal cells, there's no clumps. And for the coagulation profile, there will be prolonged bleeding time, but there will be normal PT and HTT because the coagulation factor is normal. And next one, we can do the bone marrow examination. So for the bone marrow examination, we rarely do, but we only do if the patient is not responding to the therapy or before we start the steroid, because we want to avoid if the patient has leukemia or maybe the patient has the aplastic anemia. And our expected finding is there is the increase in the nasal parasite. And we can also do the auto immune profile like DNA, NCBS, DNA, and also the antiplatelet, because the SLE can also cause the thrombocytopenia. And lastly, we can do the HIV screening or Hep B screening, because especially at the person who at risk, like the parents with the HIV infection. Okay, the last one is actually the management for ITP. So ITP again, it can be resolved spontaneously. So usually there's no treatment that we can we do for the children, because in most of the children it's carrying spontaneously, and around 70% will achieve the platelet count more than 50 times 10 to the power of 9 per liter by the end of the third week without treatment. So what we can do for the child is that we give advice to the parents. So we ask the parents to take the precautions with the physical activities, especially the small children, since they are very active. And then we ask them to avoid any contact sports, to seek medical attention if there is any significant disease, and avoid aspirin and anything if they are antiplatelet. And then there's a group of patients that we just observe and monitor, which is if the patients have the platelet count which is more than 20 times 10 to the power of 9 per liter without bleeding, or if the patients have the platelet count more than 30 times 10 to the power of 9 per liter with only cutaneous purpura. And then we need to repeat the FTP within the first 7 to 10 days to ensure that there is no evidence of involving neuro disorder. And there's also sometimes we need to admit the patient to the hospital because there is a severe life-threatening bleeding, such as intestinal hemorrhage, regardless of the platelet count. And then we also have the patient that found with the platelet count less than 20 times 10 to the power of 9 per liter with bleeding, or maybe there's no bleeding, but there is inaccessible to the healthcare. And also, if the patients lack of confidence for the home care, so we can admit the patient to the hospital. So in hospital, we will give a treatment for the oral penicillin, which is around 2 milligram per kilogram per day for 14 days. Then we taper off for 5 days, and then we give 4 milligram per kilogram per day for 2 to 4 days. And then we can also give the IV immunoglobulin or IVIG, which is around 0.8 gram per kilogram per dose for a single dose. But we need to take note that the IV immunoglobulin can cause the side effect, which is around 15 to 75%. So it can cause fever, flashing, headache, nausea, affected meningitis, and also there's other possible transmissions of the blood-borne infection, such as hepatitis C, especially in the older population. And then in the emergency treatment, so we need to give the IV methyl penicillin around 30 milligrams per kilogram per day for 2 days, and or we give IVIG 0.8 grams to 1 gram per kilogram as a single dose, or we combine this if there's the life-threatening condition. And we can also give the patient the platelet transfusion if the platelet count is low. And we can consider the splenectomy only if the other modalities fail. Okay, so that's all from the management. So this is one of the sample states that are found in the textbook regarding the ITP. So let's see it. Firstly, CN, age 5 years, developed bruising and a skin rash over 24 hours. And she had an upper respiratory tract infection the previous week. So the upper respiratory tract infection, so it can be viral infection or it can be bacteria, but this can be the history of the infection. And on examination, she appeared well, but had a purpurate skin rash with some bruises on the trunk and leg. So this is the clinical presentation for the ITP. There were black blister on the tongue and the buccal mucosa. So there is the mucosal bleed, but no fundal hemorrhage, no lymphadenopathy or hepatosplenomegaly, and a full blood count showed the hemoglobin 115 gram per liter with normal indices. So hemoglobin is normal. White blood cell and differential normal. So white blood cell is normal. And the platelet count is 17 times 10 to the power of 9 per liter. So the platelet count is less. The platelet on the bloodstream were large. So this can indicate there is a limited platelet. And otherwise, the stream was normal. So a diagnosis of ITP was made, and she was discharged home. And her parents were consulted and given emergency contact names and telephone numbers. So this is because if there is any emergency bleeding. So they were also given literature on the condition and advised that she should avoid the contact spot. So this is the management where the doctor should advise the parents and then but should continue to attend the school. Over the next 2 days, she continued to develop the bruising and scura, but was asymptomatic. So okay, by the third week, she has no new bruises and her platelet count was 25 times 10 to the power of 9 per liter. So we can see that the platelet count start to increase. The blood count and the film show there's no new abnormality. The following week, the platelet count was 74 times 10 to the power of 9 per liter. So it keep increasing, right? The platelet count. And a week later, it was 200 times 10 to the power of 9 per liter. And then she was discharged from the follow-up. So we can see that it start to resolve, the ICP start to resolve itself without the treatment. So I think that's all from me. Is there any questions?
Any questions? Tak ada. Tak ada, kita proceed to the next topic.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm to Dr. Shahid and all my fellow friends. First of all, can you guys hear my voice and can you guys see my slides?
Yes.
Okay, so I will be the last presenter for today and my topic would be about hemophilia. So for my outlines, I will be sharing with you a little bit about the definition, inheritance patterns and pathophysiology of hemophilia, the clinical presentation, investigation, differential diagnosis and the management of hemophilia, and we will discuss on one case about hemophilia. So for the introduction, the definition of hemophilia is a group of blood disorder in which there is a defect in the clotting mechanism. So hemophilia is actually the commonest severe inherited coagulation disorder. It is of X-linked recessive inheritance, but in 30% of the cases, there is no family history and it is a spontaneous new mutation. There are two most common hemophilia, which are the hemophilia A and hemophilia B. So the hemophilia A, it is the deficiency of factor VIII, which accounts about 85% of cases, and it has a frequency of 1 in 5,000 male birth. For hemophilia B, it is the deficiency of factor IX, which accounts of 15 cases, and it has a frequency of 1 in 30,000 male birth. So the hemophilia, it usually affects the male, while the females usually becomes the carrier. So as we know, the hemophilia is the mutation of the genes on the X chromosome, and the male have one X and one Y chromosome, and female have two X chromosome. So this means that male only have one copy of most of the gene on the X chromosome, whereas female have two copies. So that's why male can have a disease of hemophilia if they inherit the affected X chromosome that has a mutation, either the factor VIII or factor IX gene. Female can be a carrier, but they can also have hemophilia if both X chromosome are affected or one is affected and the other is missing or inactive. So these are the inheritance pattern of the hemophilia. So for the first one, if the father does not have hemophilia and the mother is a carrier, there will be 50% chance of each son to have hemophilia, while there will be 50 chance of each daughter to be a carrier. The second scenario is if the father has hemophilia and the mother is not a carrier. So the sons will have a 0% chance to have hemophilia, while the daughter will be the carrier of the, will be the 100% chance for the daughter to be the carrier of hemophilia. For the third scenario, if the father is hemophilic and the mother is the carrier, so there will be 50% of a 50% chance for the sons to have hemophilia, 50% chance for daughter to be a carrier, and 50% chance for daughter to have hemophilia. For pathophysiology, so the underlying pathophysiology of hemophilia, it is initiated when there is breach of the endothelium of the blood vessel, maybe due to trauma or any surgery, and this will initiate the hemostasis. So this will enable the tissue factor to contact and activate the factor 7. And the activated factor 7, which is the factor 7A, it will initiate a limited coagulation cascade, and it does not depend on factor 8 and factor 9. So it only produce a small amount of thrombin. So as we know, thrombin is actually a crucial component for early clotting process, whereby it includes the activating platelets to aggregate and plug the collagen to the submedullary surface. And it also converts small amount of fibrinogen into fibrin. During the secondary hemostasis, there will be increased amount of fibrinogen. And this fibrinogen will be converted to fibrin to stabilize the thrombus. And factor 8 and 9 is required to amplify this step and forming a complex to activate the factor 10. So if there is deficiency in factor 8 or factor 9, they will be result in compromised factor 10 activation, and they will be result in suboptimal thrombin generation, and there will be inadequate clotting production and will result in bleeding tendency. This is another diagram to show the pathophysiology of the hemophilia. So as you can see, when there is genetic defect on the X chromosome, and when it affects the factor 8 or factor 9 gene, there will be deficient in the factor 8 and factor 9 in blood. So there will be, since factor 8 and factor 9 involved in the intrinsic clotting pathway, there will be increase in APTT. However, there will be normal PT because these two factors does not involve in the extrinsic clotting pathway. The deficient in the factor 8 and factor 9 will also cause insufficient clotting when there is a bleeding tendency, like I said before, in let's say if there is surgery or bruising, and this will lead to uncontrolled bleeding. So this uncontrolled bleeding can lead to hematrosis, which is bleeding in joints, intramuscular hematoma, dental bleeding, intracranial hemorrhage, or GI bleeding. In severe patient, there will be repeated joint bleeds. And these repeated joint bleeds can cause chronic hemophilia arthropathy, and this is the main contributor to disability and reduced quality of life. So for the classification of hemophilia, there will be three classifications. The first one is mild. This is when the factor level is about 5 to 25%. And the clinical presentation would be the bleeding may only occur with trauma, surgery, or dental procedures. For moderate hemophilia, the factor level would be about 1 to 5%. And will also presented with bleeding that may only occur with trauma, surgery, or dental procedure. For severe hemophilia, the factor level would be less than 1%, and the clinical presentation would be spontaneous bleeding, and there will be risk of intracranial hemorrhage. For history taking, for HOPI, so the first thing first, if the bleeding is when the bleeding occur during neonatal period, which is less than 28 days, because bleeding usually is unusual during the neonate period. And the onset also when the onset of the bruising is when the patient started crawling or walking, which is during the 9 to 12 month age. Besides, patient will also presented with hematrosis, which is the hemorrhage of the joint, and it is the hallmark for hemophilia. And last joints can also be affected, such as in the knee, ankle, and elbow, and the joints usually swollen and painful. There were also other sites of bleeding, such as the epistaxis, gum bleeding, and hematuria may also occur if genitourinary system is involved, and intracranial hemorrhage may also occur, but it is a life-threatening event. So for aggravating factor, it's not preceded by trauma and spontaneous if it is a severe hematuria. For the associated symptom, there will be lethargy, swollen and painful joint or muscle, abdominal pain, black tarry stools, hematuria, headache and neck stiffness.
Hilang dah presenter.
Assalamualaikum warahmatullahi wabarakatuh. Sorry, my internet just disconnected. Okay, so I will continue. For the clinical presentation, so what we will find are the easy bruising, gum bleeding, hematosis, hematoma, and epistaxis. So during physical examination, what we will find is systemic signs of bleeding such as tachycardia, tachypnea, hypotension, and orthostasis. So we will also find for any organ system specific sign and symptoms of hemorrhage, such as if there is hemorrhage of the musculoskeletal system, there will be tenderness, pain with movement, decreased range of motion, effusion, and warmth at the affected joint. If it involves gastrointestinal, usually it can be painless, but usually it present with hepatic or splenic tenderness and peritoneal signs such as bloating or fever, nausea, and vomiting. If it involves genitourinary system, there will be bladder spasm, distension or pain, and costovertebral angle pain. And if it involves central nervous system, there will be abnormal neurological exam findings, altered mental status, and meningismus. So for investigation, the first investigation that I would like to do is the full blood count, which we expect a normal finding. We will also do screening, which is the prothrombin time, which should be normal. Prolong for FPGT, it should be prolonged because it affects the intrinsic pathway. The platelet count should be normal, and the von Willebrand factor should be normal. For mixing study, so this study is to distinguish whether the prolongation of the clotting time is due to the factor deficiency or the inhibitor of the factor. If after the missing study, if the ability is corrected, it means that it is the prolongation is due to the factor deficiency. However, if the APTT is not corrected after the mixing study, it means that there is presence of inhibitor. And we will also do specific factor assay, which is factor 8 and factor 9. So there will be low factor 8 level in hemophilia A and low factor 9 level in hemophilia B. So further investigation that I would like to do is Hep B surface antigen and anti-Hep B surface antibody. hepatitis C antibody and HIV serology. This is because the complication of hemophilia are that the patient can easily are at risk of getting viral infection. I would like to also do liver function test to know whether the hepatitis affect the liver or not. And I would like also do diagnosis of carrier status for genetic counseling. So those that need to undergo diagnosis of carrier status are mother of a newly diagnosed son with hemophilia, female siblings of boys with hemophilia, daughter of a man with hemophilia. For the differential diagnosis, we have several differential diagnoses of hemophilia. The first one is the one with brain disease, where it is an autosomal dominant. So the bleeding would be the mucosal bleeding, and the abnormal finding would be the FPTP, either is where it can be prolonged, and there will be low factor VIII level, and other blood profile will be one with brain factor where it will be low. For platelet disorder, usually it is an autosomal disorder. The bleeding is usually spontaneous and excessive. And another blood profile that should be done is platelet level, and it should be low. For another differential diagnosis is factor 11. It is an autosomal recessive, and usually the bleeding is preceded by trauma. There will be prolonged APTT, and there will be also low factor 11 level. Next is factor 12 deficiency, where it is an autosomal recessive. There will be no bleeding problem, but there will be prolonged PT and APTT time, and also low factor 12. Next, factor 13 deficiency, where the mutation is autosomal recessive. There will be prolonged bleeding, and there will be low factor 13 level. The second last is the combined factor 8 and factor 5 deficiency, whereby the mutation is autosomal recessive and the bleeding would be spontaneous. There will be prolonged APTT and PT and low level of factor 8 and factor 5. The last one is acquired factor inhibitor. The bleeding would be in the soft tissue, and there will be prolonged APTT and low level of both factor 8 and factor 9 level. So for the management, so ideally the management of the hemophilia should be prophylactic to prevent arthropathy and ensure the best quality of life. So the dosage of factor, for example, for factor 8 concentrates, it would be about 35 to 35 U per kilogram, which is given every other day or 3 times a week. For factor 9 concentration, for factor 9 concentrates, we give about 40 to 60 U per kg and given every 2 to 3 days. However, it is costly and requires central venous access. Another treatment option is factor replacement therapy when the clotting factors are inadequate. So for factor 8, we concentrates we give to hemophilia A patient, and we give it about every 8 to 12 hours. Factor 9 concentrates, we give this to hemophilia B patient every 12 to 24 hours. And we did not use fresh frozen plasma and cryoprecipitate in order to avoid risk of viral transmission. And also the dosage of factors can be the dosage of factors are different for types of bleeding. For example, in hematrosis, the factor 8 dose should be about 20 U per kilogram. For factor 9 doses, 40 U per kg. For soft tissue or muscle bleeds, we would give 30 to 40 U per kilogram for factor 8 and 60 to 80 U per kilogram for factor 9. For intracranial hemorrhage or surgery, we will give about 50 U per kilogram factor 8 and 100 U per kilogram for factor 9. So for supportive treatment, we have the analgesic, whereby it can give rapid pain relief in severe hematrosis. When the missing factors concentrates is increased. However, we should avoid intramuscular injection, and we should also avoid use the use of aspirin or NSAIDs, as they will affect the platelet function. For dental care, so it is so a good dental hygiene is crucial because dental caries is a regular source of bleeding, and dental clearance with factory replacement is also required in severe cases. The last one is immunization, whereby it is important and must be given through subcutaneous route, and you should give under factor cover if hematomas are the problem. So for the example of this discussion, so for the patient history, a 4-year-old Malay boy presented to the emergency department with a chief complaint of oozing blood from his mouth following a fall nearly 6 hours ago. His mother explained that he tended to bleed for prolonged periods from his immunization sites. There were other history of bruising and hematoma following falls. Her mother is unsure of any spontaneous bleeding episodes. There was no known family history of a bleeding disorder. For physical examination, generally alert, in no apparent distress, development appropriate for age. For HEENT, there are 2 small lacerations on the inside of the lower lip, and there is oozing blood at the side too. And the remainder of the exam, there is no peculiar bruises or joint swelling. So my provisional diagnosis would be hemophilia A because there is bleeding following trauma, and there is also prolonged period of bleeding previously. However, there is no spontaneous bleeding episode. And so for the negative point, there is no spontaneous bleeding episode and no family history of a bleeding disorder. My differential diagnosis would be hemophilia B, one Wilbrand disease, platelet disorder, factor A and factor 5 deficiency, and factor 11 deficiency. So during investigation, it is found that the APTT is prolonged and the factor 8 is low. So my final diagnosis would be hemophilia A. So that's all from me. Thank you. Do you guys have any question?
Any questions? Okay, so I think last week ada satu patient hemophilia masuk kan? Dia kasi tak?
Actually, we are in Kuantan, doctor.
Oh, last week?
Yes.
Dia tak pernah jumpa ada seorang patient. Dia masuk for 1 week kot. Ada macam cuff hematoma. Tak sempat jumpa lah.
No, doctor.
Okay, alright. So patient tu memang non case of hemophilia A lah. Memang on weekly factor replacement. Came with hematoma at dia punya cuff dia lah. Okay. So all these recurrent hematoma at dia punya muscle, at joints, okay, is very important to avoid lah, because it can cause scarring and then further nanti deformity dekat joints dengan muscle lah kan, develop scarring. Okay, any questions? Okay, tak ada soalan, kita boleh bersurai. Thank you for the presentation. All very comprehensive presentation lah. I think nothing to add on to the presentation. If you have any more questions after this, you can WhatsApp lah dekat group ni.
Thank you, doctor.
Thank you, Doctor.
Thank you, doctor.
Thank you, doctor.
Thank you, Doctor.